Hello, good morning. I'm going to share my screen here. So, my name is Camila. I'm from University of São Paulo and University of Brasília, both in Brazil. Unfortunately, I wasn't able to attend in person to the event, but I'm very glad to be presenting one more part of my PhD research in this event with such great colleagues, researchers. So I don't know how many of you were in the same room earlier, but as I said, well-being is highly related to mental health, and suicide, if not the most, is one of the most tragic outcomes when a person is experiencing psychological distress. So suicide prevention is the main topic of my PhD research. And now I want to talk about some of the findings we had in the study about Brazilian college students. So most of you might already know that suicide is one of the leading causes of death among youth from 15 to 29 years old. During the adulting phase, youngsters are highly demanded for taking more responsibilities and autonomy over their social and professional lives. Along with these transitions, students struggle in adapting to a demanding academic routine, and the lack of social support, financial difficulties, low academic performance, and pressure to succeed can exacerbate the likelihood of mental illness and suicidal cognitions during this transitional phase. So some studies have suggested that academic institutions might confer some protection from suicide, given that college students present lower rates than their same-aged peers that are not enrolled in the course. However, a recent nationwide study in the United States indicated a rising trend in the prevalence of suicide ideation among students. So the gaps we can find in the current literature is that there is still no consensus about the interaction between suicide-related factors, because distinct models provide varied perspectives on the phenomenon of suicide. Given the complexity of suicide, it is actually very hard to achieve consensus on the clinical applicability of the knowledge about suicide risk factors itself. So it is very important that we examine critically the factors associated with students' suicidality, so we could identify vulnerable groups and then develop preventive strategies. Very few studies have investigated the relationship between suicide and academic variables among college students. So there is a need for studies with representative samples to identify which are the manageable factors related with students' suicidality. So aiming to fill up this gap, our main goal was to investigate the prevalence of suicide ideation and its associated factors in a nationwide sample of college students. The data we used in the study were drawn from a nationwide cross-sectional study on the use of alcohol, tobacco, and other drugs among college students from the 27 Brazilian state capitals. The sample of the survey is a probabilistic random sample with 2 stages stratified by clusters of different sizes. And so in the first step, the higher education institutions were randomly selected using the schools list that was provided by the Brazilian Ministry of Education. And after agreeing to take part in the survey, the institutions provided a list of all classroom-based undergraduate programs, which allowed the researchers to randomly select the classes. So all the students that were selected, of the selected classes, were invited to volunteer for the study, and the response rate was 95.6%, considering the students that were in the classes at the time of the survey. Considering the questionnaires that were excluded because respondents claimed to use a dummy drug or because they did not answer the suicide ideation item, The final sample we consider for the present study included 12,245 valid questionnaires that were considered for this analysis. So all the students completed a structured, anonymous, and self-administered questionnaire consisting in 98 closed questions with social demographic characteristics, academic characteristics, drug use and related disorders by the assist instrument, risky behaviors, psychiatric comorbidity by the Beck Depression Inventory, the short K6 scale for psychological distress, the psychotic-like experiences from the self-report questionnaire. For the analysis, we conducted a logistic regression used to investigate the associated factors for suicide ideation and adjusting for covariates. The coefficients were reported as odds ratio with the 95% confidence intervals. Also, all the estimates were in the analysis were weighted to obtain unbiased estimates for the study population. We built a conceptual framework to describe a hierarchical relationship between potential suicide-related factors among college students. So to organize the variables, our conceptual framework, we consider the contextual factors of students during the college period. Social demographic characteristics, earlier diversities, and mental disorders interact with each other, increasing and decreasing the suicide risk. This is already known. And in addition, we hypothesize that academic characteristics can indicate psychological distress and ultimately be associated with suicidality among students, as pointed out by some previous studies. Regarding the mental health, we found that almost half of the students presented at least one psychotic-like experience in the past month, and more than a third presented psychological distress. And for suicide ideation, we found a prevalence of almost 6% of the students. We found no comparable study focusing on suicide with a representative sample of college students in Brazil. So we had to compare with other studies. Obviously, it is not the ideal, but we found some studies from other countries that we could try to compare a little bit our findings. The suicide ideation we found in a large-scale sample from the United States ranged from 1.9% to 14.9%. And a large meta-analysis with students from 36 different samples indicated a year prevalence of 10.6% of suicide ideation among college students. So 5.9%, that was what we found. It's kind of in the mid within this findings also. So furthermore, a considerable proportion of these meta-analysis, about 20% of the students with suicide ideation reported subsequent suicide attempts. This is not a small number and should serve as a warning call over students' mental health, bearing in mind that not all suicide ideators will progress to attempts. So there is a big window for intervention during the gap between the onset of suicide ideation and self-harm behaviors. Regarding the associated factors, this is a detailed table of the logistic regression results of the distal variables, social demographic, and history of sexual abuse. Here you can see that economic strata had a marginal effect on suicide ideation, being higher among those with lower economic classes. We found also that having a religion and having children were associated with lower likelihood of suicidal ideation, and that victims of sexual abuse had more than 3 times the likelihood of suicide ideation than those who had never been abused. The students that stated to having forced someone to have sexual intercourse also presented higher odds for suicide ideation, but this estimate is inaccurate once the confidence interval is very large. And here presented detailed tables of the results of the academic and mental health variables. Students that thought about dropping out the program or taking a leave of absence presented more than 2 times the likelihood of suicide ideation than those who had never thought about it. And the students that were not satisfied with the chosen undergrad course had 86% higher odds of suicide ideation than those who were satisfied. And those with a lower performance in the last semester had more than 3 times the likelihood of suicide ideation than those with a higher performance. The number of attended courses also was associated with suicide ideation, but once again, these estimates are very inaccurate considering the confidence intervals. Finally, regarding mental health, students who were mentally ill in the last month have 5.56% higher likelihood of presenting suicide ideation in the last 15 days than those who are not mentally ill. And students who presented at least one psychotic-like experience in the last month had more than 2 times the likelihood of suicide ideation than those without any psychotic-like experiences. So summarizing all this information and the final regression model, the clinical factors that were associated with the likelihood of suicide ideation were psychological distress, history of sexual abuse, and psychotic-like experience. This association with clinical factors are already known in the literature, but I like to highlight that here is the association with academic variables. As presented in the tables, we saw that the students that failed all the subjects thought about dropping out the program or were not satisfied with the chosen undergrad course had higher likelihood of presenting suicide ideation. And also our results, as expected, because the previous literature already shown that there is a protective effect for those who are parents or claiming to have a religious affiliation. I wanted to highlight the academic factors because I believe that they are more observable and manageable in a short term than mental health itself. And for this reason, they could serve as important indicators that something is not okay with those students, serving as an initial point for mental health promotion and suicide prevention interventions. The dissatisfaction with the university is related to the levels of stress amongst college students already in previous literature, similar to the effect of life dissatisfaction with suicide ideation. We believe that these content students might have more difficulties in finding reasons for the academic efforts and have higher likelihood of engaging in self-harm thoughts. Both the attrition rate and the desire to drop out have been associated with feelings of failure, hopelessness, anxiety, and burnout. Therefore, it's very reasonable to argue that suicidal cognitions might be activated when vulnerable individuals are under academic pressures and need to cope with stressful situations. Thoughts of dropping out and negative feelings towards the academic environment might impair the students' motivations, jeopardizing their academic performance and satisfaction with college. So finally, the relationship between poor academic achievement and suicidality is well known also among adolescents and high school students, especially when self-demanding perfectionistic beliefs are activated during stressful contexts. In college students, academic failure could lead to a sense of defeat and humiliation, so it could boost the entrapment feelings for those students. As said, these indicators should be urgently considered by university staff and professors to identify vulnerable individuals The early identification of students with potential psychological distress and suicide risk could bring out an important window for timely intervention. Our results provide background for university stakeholders to examine and to identify their students' vulnerabilities in the social and academic contexts. And knowing this, efforts should be implemented to avoid the progression of ideation to acts of life-threatening behaviors. Prevention plans are already recommended for vulnerable groups, and it's recommended that it combines different levels of strategies. Awareness and education for mental health promotion could help to build important skills among students, reinforce protective factors, increase knowledge, protective attitudes, and help-seeking behavior. And finally, combining these strategies to facilitated access both to mental health care services and other supportive academic service could intensify the preventive effect. So this is it. Thank you for your attention. And if you wish to read more about the research or to get in contact with me, you can scan this QR code or access this link tree or send me an email. Thank you so much for your attention.
So thank you, Altavini. I think the question of students who drop out of school, university, really is an important focus for intervention. So when you have a student who's threatened, then you really need to think about interviewing and seeing if that person is well cared for. So we're going to have questions at the end, not each session. So I can call upon our next speaker, Dr. Dawn Fox, who's a senior lecturer in the Department of Chemistry at the University of Guyana, and she's head of the Department of Psychiatry and Voluntary Life Services at the VHS in Chennai.
But I'll fix it.
Okay. Sorry. So, well, I'll read what it says, and you can
I'll fix it.
you're a senior lecturer and head of the Department of Chemistry at the University of Guyana. Her overarching research interest is in converting local materials into filters and solvents for improving water quality. She's 20 years experience as a tertiary educator and is passionate about creating informative learning experiences for students. She has several peer-reviewed journal and conference proceeding publications, one book chapter, and hosts 2 papers. In 2018, she became the first BMA recipient of the Organization for Women in Science and Development. So Dr. Fox, apologize for the mistake, but very interested in everything.
Thank you. Good morning, good day, everyone. Great, looks like we're in the second business. It feels strange to be sitting. I like to stand and present, so don't be alarmed if I jump onto the seat at some point. So as you heard, my name is Dawn Fox, and I'm from the Department of Chemistry at the University of Guyana. And I am so excited to have this opportunity to share some of the lessons that we learned in that emergency pivot to online teaching when we had to do the pandemic. I am not a mental health professional, but what I am an educator, and the stressors that affected both the students and the faculty, that was our lived experience. So I just want to congratulate the previous presenter. Those things were really real for us. I was warned about the mouse. So as I alluded, the context was COVID-19 pandemic, and that is something we all share. Each one of us in this room is a survivor of a global pandemic. And sometimes we don't stop and appreciate that. So that was a shared experience, and it was different for different persons in society. The healthcare workers, they were the front line, but educators also.
Sorry to interrupt.
Sorry.
All right. Is there anybody who drives this car? PPP 7912. Okay. So,
So I was mentioning that the pandemic that we have all collectively experienced, we experienced it differently, and for educators, it meant a complete digitization of all the things that we did face to face. And the term is emergency remote teaching. We had to quickly pivot to online, whether you were ready or not. And that introduced several stressors on the educators as well as the students. But what we found is that most of the research done on mental health deterioration actually focused on students, but not on faculty. And that is where we wanted to address them so that the faculty can be well. I don't think I need to convince anyone in this room that you need the faculty to be well to interact with the students. And so the lessons we learned there, as we came out of the pandemic, we realized that things are not going back to how they were. For instance, this conference is blended. And so the new normal, we have to build on some of the things that we've learned. So the lessons are still relevant, even though they were developed in that high stress pandemic period. Now that online teaching is becoming the norm, we're going to translate and build on some of those experiences. So here I try to interact or live the experiences as well as corroboration that we got from the literature to see some of the things that helped us to cope in that time and that can help to support us and help our well-being as we continue with online teaching. Okay, all right, so, okay. So do I abandon the mouse entirely? Because is it a touch screen? Can I touch? No? No, not yet. So on this screen, I was giving, this is the original slide that I was talking about, some of the experiences that we had during the pandemic. Things like, when last I've been outside, that's Guyanese curlews for foreigners. We had a lot of competition for our time, and we end up spending a lot of time in Zoom meetings. And this is just a sample of some of the different things that we all did, including educators. The stressors, if not acknowledged, could lead to physical and mental illnesses. And we were seeing that among ourselves. We were seeing that among our peers. We were seeing it in our students. And in the pandemic, we decided that maybe we can come together and speak about it to find out what can we do to alleviate it as we are living it. Thank you. The emergency remote teaching, we shared our experiences, and what I was surprised to find is that some of the things that we were experiencing, educators around the world were experiencing. It didn't matter the level of development of the economy, it didn't matter the culture, geographical differences. There were a cluster of things that we shared in common. And for many of us, the newness of that transition to the online teaching was a major stressor, particularly as we had different competencies, different levels of comfort with interacting with ICTs. We had to cater for resource gaps. It could have been training gaps if you didn't have the competencies, but some of those were also technical and infrastructural gaps. And then we had to work from home. That introduced other stressors, work-life balance, and that was actually felt in the research and in our lived experience. We saw a difference in gender in terms of the stresses on our work-life balance, when the women who had a lot of role in family care end up having a lot of role fatigue, because in the home you suddenly are the professional, but you're also the caregiver, you're also the educator, not only for your profession, but also for your children who are now at home. Workload increases. This is actually tied very closely again to the newness of flipping to online. You have to learn how to transform your teaching materials and your assessments into digital media. things that you usually outsource to somebody who's competent. Now it fell on you, and you had to suddenly learn or try to learn and adapt to all of these challenges. So I'm a chemist. Part of my work is in a lab. Labs are closed. So for almost 2 years, we had productivity decreases. Now I'm going through these to give you an idea of the buffet of stressors that hit educators, that we didn't really have intervention in real time. So we had to come up with, okay, so what are we going to do about it? And in our team, we actually had what we call an on conference, and this was actually part of that on conference, where we just shared what we knew. So those who were good at ICT, they came and they shared some skills. And one of the things that they thought was interesting was that, yes, we do see differences in our well-being and our mental health. What can we do about that? So I'm hoping to, thank you. Share with you some of the common stressors that we articulated and some of the lived experience interventions that we did to try to overcome them. So on the left, I have a list of the stressors, and on the right, I have a list of the different behaviors that we are advocating and promoting and trying to engage in. And this is what the entire presentation will be about. So one of the things was increased time pressures, and the protector for that stress was, can I be better at planning the use of my time? Another thing was e-communication overload. It was the only way to communicate. How many people went to parties on Zoom? That was it, right? So that added to your previous levels of communication, and I know universities are well known for high email volume. That led to, email and communication overload. So can we manage e-contact? I felt keenly the lack of human connection to my students and to my peers. What can we do about that? Many of my peers, many of my colleagues spoke about the isolation and the loneliness of online teaching. So could we create that community virtually? And what probably went a bit unacknowledged was that in trying to focus so much of your energy on the fixes, we didn't pay that much attention to our physical and mental well-being, self-neglect. So prioritizing that in order to overcome the stressors. So the first discussion was about the time-intensive nature of online teaching, particularly when you're learning as you go along. And there are only 24 hours in a day. The best we can do is to use it better. So the antidote for that time pressure stress was jovially become a planning ninja. In other words, pay real attention and structure the time and how you use it. It helped that going into the pandemic, if you already had structure, especially for preparing for classes, and that's why I'm giving a shout out to a course I did on Coursera called How to Be a Together Teacher, where the focus was on when you're managing time, it's not only about your work. You have to set aside time for all of the life supporting activities. You need to sleep, you need to cook, you need to go shopping for groceries. Those are life supporting activities. You need to exercise. And scheduling it. It's not intuitive to schedule these things. We say, oh, it's going to happen naturally. But when other competing things come in, it probably won't. Thank you. So I just say next. No, not the next slide, just there. Thanks. So there's a flexibility that you have with an in-person interaction or an in-person class that is not there in an online situation. So you need to plan for it. Whatever experience you want the students to have, you have to create it well before the class. So scheduling time, part of that time is scheduling your lesson planning, and there's a ton of information. I'm not gonna go through all of that. There's a ton of information on the internet as to how to create a transformative online experience to parallel the benefits of the in-person. Next slide. So why invest time in that? For one, as an educator, one of the things we're interested in is the quality of our classes, and a well-planned experience can improve that. Better technically prepared, if you know in advance you're going to need a tablet or a functional mouse. Better prepared for meetings because you already planned to attend it, so you do before. I think one of the things that is really important is being able to better support a work-life balance. If you plan your activities, then you can plan the time you spend on work and non-work activities. Some of the challenges that we experience with that are that if you are not accustomed to really planning out your time, in that it can feel counterintuitive. It takes time to plan your time, and you always feel like maybe I could be doing something better, right? The benefits only come if you're consistent, and the consistency requires discipline. So no, I'm not a planning ninja, but I try. The next chapter that we looked at was the email overload, and in the literature, it was well linked to workload stress. There's an expectation when it hits your inbox that there's a quick turnaround, but you don't have time to give a quick turnaround to everything that's in your inbox. And then you can feel overwhelmed by a high volume, especially some of them are not critical to your work function. In addition to that, the e-contact has now gone over into our mobile phones, where even that has become a work tool. How many work messages you get on WhatsApp? How many meeting links are done actually on your phone? So that also adds as a stressor. And if it was large before the pandemic, during the pandemic, it exploded. So how do we counteract, next, the stressor of high e-contact is finding a way to manage it. So I know I see everybody with their phones in their hand. It might feel like cutting off a limb to put away your phone for a high focus time. It is doable. I've done it. I survived, right? You can survive without your phone for 3 hours at a stretch. The world will not fall down. Checking your email every minute actually adds to your anxiety and stress, particularly if you can't get to the work that you need to do at that time. So it's better to schedule a time that you're going to check your email at certain times in a day. And at that time is when you're going to actually work on it. When I see it, I'm going to take the action. No sense reading it, feeling anxious, can't work on it, and it's on your mind as you try to do other things. So this OHI was only handled once. Try to read, execute, be done with it. It sounds nice in principle, it's not always that easy. So managing the contact from students, if you have a class with 600 students, you do not want them all messaging you every day. So you need to set boundaries on how you're going to communicate and how quickly you can communicate with the students. And when you make those commitments, you have to honor them. The students get anxious when they feel like you're not responding to their queries, and then they go and start bothering somebody else. This person is not responding to me, I can't find it. So set up reasonable expectations, but then follow through. And some communication can be automated. For example, one of the things I found useful was scheduling apps. Scheduling apps help people to go to one space and say when they're free, and we find a nice time for the meeting. That took up about 40 emails back and forth. So those are some of the things that you can do to manage it at that time. That we found to be useful. Click to fast, so I don't have to do it again. No, we went too far. One down. Great. Now you can read for yourself. When you need to focus to get, for example, writing done, the last thing you want is your phone pinging all the time. So you actually become more productive if you spend less time and less distractions, less interruptions with your device. When you get there, when you finish, the messages will still be there, and you can attend to them when you're ready. But it's not that easy to do. If it were, then everybody would have already put away their phone by now. Right? So it's something that you have to practice. And if you see the benefit of it, then you will be encouraged to say, okay, I can turn it off for 2 hours in the morning and get some important work done. There is the chance that you might miss something time sensitive. But the way that I rationalize that is I need to be protective of my time, and people also need to be respectful of my time. it is not fair for you to impose an emergency deadline on me, and expect me to drop everything to get that done. Your supervisor might not like to hear that at all, but that is a better way of approaching and being productive in the long term. So this is one that I personally struggle with, is on pivoting to online teaching. I found it very impersonal. Like, I'm really enjoying being able to look at you and to get the cues. So I can hear if there's a sidebar conversation that tells me, time to wrap it up, people, I'm losing you. You can't do that if you are online. There are other ways that you can interact, but getting that cue from your audience, it's difficult. So it feels, I told my niece, it feels like talking to a wall. So there are ways that you can try to establish that human connection, even though it feels like you're talking to a wall. So before class, you can have an introductory icebreaker, get to know what are some of their pet peeves, something that they like. Have a sidebar conversation that has nothing to do with chemical engineering or material science, and hopefully that icebreaker, that chattiness will roll over into them being responsive in class time. If you are strong enough to show your vulnerability, who knows, your students might open up to you about theirs. And the benefits are that even in this online situation, you can still get to know your students a little better. The students get to know each other a little better because they too are being isolated from each other in online. And the silence that I find difficult to deal with, that silence, you can break that silence. The students might feel a little safer to try to interact more in those situations. The challenges is that sometimes, despite your best efforts, you still get a wall of silence. And one of my colleagues, she told me that, well, that doesn't mean that they're not engaged and that they're not learning. Right? They probably just shy to open up in front of everyone. So this isolation that I'm talking about here is about from the colleagues now. So I'm separated from my students, but I'm also separated from my colleagues. And there are benefits from being in the same place and being able to go down the corridor to a colleague to solve a problem. There are benefits of collaboration, there are benefits of just social interaction, and that was not there when we were on lockdown. And even coming out now, we find that most of our meetings are still online. So some of that isolation has remained even in our new normal. And so to counteract that, what we found useful was to find and create virtual platforms. Now, there's a conflict there that is the same platforms trying to run away from because you're on it all the time, but the interaction there is different. So the virtual community of learning and virtual community of support took the place of being able to go down the corridor and chat with a colleague. So the conference, and we had that on conference, that was one of the outcomes of that. We were able to come together and have that conference to share with each other, how can I manage this? How can I deal with my anxiety over COVID? How can I get resources to improve my lab that now I have to do simulations for? And we can benefit from the collective experience. Finally, the physical and emotional toll of online teaching. There wasn't really a space to address that. All of our usual conversation centered around the pedagogy and around the science and the practice. But then what about the person? So if you're suffering physically and emotionally, how can we take care of ourselves, especially if you're not in a situation where you can access help? So the self-care became one of the focal points for long-term well-being. And when you hear self-care, you probably think of bubble baths and lighted candles and pampering, and that's good. But it's a little bit more holistic than that. It's about your total physical and mental well-being. And for some reason, we think that, oh, we put that on a back burner. But what we couldn't put on the back burner was how we felt after sitting for 8 hours or more in front of the computer. So prolonged sitting, medical professionals who are here will know, has been associated with several physical health indicators as well as mental health deterioration. And they say, if you click on it, you'll see and put a band there. Sitting is the new smoking. And when we pivoted to online, we found we were sitting more than ever. And that's why I wanted to stand. And I encourage you to get up and to stand as well, to break up long periods of sitting, such as the hours that we're going to spend at a conference like this, such as the hours that we spend at work. So the self-care for physical well-being, people are looking for that magic bullet. It's very unsexy and very basic, things that we already know. You need to prioritize sleep. You need to eat a healthy diet, right? You need to get adequate exercise, 30 minutes minimum per day. And if you are a prolonged sitter, like my job is, then you probably need more than that to counteract those negative health effects, right? Not rocket science. And then checking up those annual checks, you know, when last you did your blood pressure, your glucose, all of those, that's self-care. Not just the pampering part of it, but the daily things that you do consistently to maintain a physical health, as well as, I'm gonna skip through, as one back, that's okay, as well as our emotional health, right? Particularly in the workplace, I think more conversations about preserving our emotional health need to happen, and some of the activities, it is an active thing we need to do to protect our emotional well-being. So I have a few, I've listed a few there. In the interest of time, I'm not gonna read them all, but emotional self-care looks different for everybody. What might work for me might not work for you, but that is where the intervention of a counselor, speaking with a counselor, can help you determine, maybe by trial and error, something that can fit into your lifestyle, something, because if you have to do these things consistently to get the benefit. So with that, I would like to thank you for your attention and acknowledge my colleagues who share their experiences with me that I could share with you. And my biggest supporter, my husband, Mr. Terrence Fox. And at the end of our session, I'll be more than happy to take questions. Thank you.
Thank you very much, Dr. Prof, for the very helpful advice. I have a several email over myself.
Okay.
I'm going to take your points and try and do them. Okay, so we can go into the last speaker. She's a graduate of Northampton University in the UK and social worker. She's active in many projects in mental health here in Ghana. And she's going to talk about therapeutic attendance and children for health. So.
So good morning, everyone. So as our moderator would have indicated, my name is Cilandell Glen. And in addition to what we've said, I'm currently the acting director of the Adults and Health Ministry of Health. And I'm also the founder of a local NGO called Desert Flower Guyana that seeks to improve mental health and well-being among children and adolescents. As was mentioned, I would have studied in the United Kingdom, so I have a master's degree in child and adolescent mental health, and also a master's degree in social work from the University of Guyana. So my study that I'm going to share with you today is a study that I would have conducted as part of my academic studies for my master's in social work at the University of Guyana. We would have had to complete a practice research project, and I would have chosen to look at the experiences of children and adolescents accessing mental health services in Guyana. So it's titled An Exploration of Adolescents' Experience of Accessing mental health service primarily at the Georgetown Public Hospital and the mental health unit and adolescent story. Now, what I would like to share with you before I actually go into the presentation is that this study cannot be fully generalized to the entire adolescent population in Guyana, because you will see in terms of the research method I would have used IPA, which is a study that used a minimum of 4 participants. And because it was a practice research project and not a full-blown thesis, we cannot make that generalization. So a little background into the study. As we know, mental illness is one of the issues that are significantly affecting the adolescent population, but it's something that is not generally talked about or researched about primarily again. If we look at the research across the UK or Canada or the other developing countries, it is something that is looked at. So during my experience in the UK, while I was doing my master's in child and adolescent mental health, I would have recognized that it's the area that we really need to pay more emphasis on in Guyana. So when I came back to complete my master's in social work, I decided to do research in Guyana. My research for my master's in child and adolescent mental health was done primarily in the United Kingdom with no stats from Guyana. So when I looked at the literature in Guyana, I would have seen that there's little to no research that is being done when it comes to mental health. As much as we talk about mental health, we don't have a lot of research that is being done, or even if research is being done, it's not published or shared among the Guyanese population. So that's the area that we really need to work on. As mentioned also, there's an increase in difficulties that lead mental health issues leads to increase in difficulties such as suicide among adolescents. And as we know, Guyana is one of that countries that have a very high suicide rate, not only among the adult population, but the adolescent population, which is very alarming and it's something we really need to look at. Research on adolescent experiences receiving mental health in Guyana, as would have mentioned, is limited. But when you look at this in terms of the UK and Canada, where I would have gotten significant literature from, it is done a lot because they utilize this research to improve not only academic studies among our children and adolescents in school, but also to implement interventions that could address and help to manage mental issues among that target population. Literature research revealed that there was never a research conducted in this magnitude in Guyana. We did have guidance who studied in further look at stigma that is attached to mental issues in Guyana and some other researches. But in terms of the actual experience of young people, I would have seen that this was never done. It makes it unclear as to what are our young people experience when it comes to accessing mental services. So I really wanted to get a sense in terms of the significance of the study is to provide an avenue to investigate a chance as it relates to mental health related issue. I wanted to produce findings to support the enhancement of mental service deliveries to adolescents and young people in Guyana. As we know, we have mental institutions, the mental health unit, the Georgetown Public Hospital Corporation, but most of these institutions don't necessarily look at therapeutic interventions for young people. It's more medicinal interventions or psychiatric interventions. So I wanted to get a sense as to what else can be implemented in Guyana. I wanted to highlight the effective intervention services that are here in Guyana to address mental issues, primarily at those 2 primary institutions, which were the Georgetown Public Hospital Corporation and the mental health unit. I also sought to provide baseline data that can be used by the adolescent department that I'm currently heading and the mental health unit, or generally the Ministry of Health, to conduct further research on mental health, more particularly as it relates to children and adolescents in Guyana, because that is my passion, to contribute to policies and strategies to address mental health among the adolescent population. Now, I'm not too sure if you're aware, but we do have the mental health gap analysis, but we don't have any particular policy that speaks primarily to children and adolescents in Guyana. And I'm happy to say that that's something that we're now trying to work on as a country, as the Ministry of Health, with support of POW and UNICEF. So very shortly, we literally have policies that speak specifically to children and adolescents for our CAMS program. So the research methodology that I would use is a qualitative research method, and I mentioned earlier, I would use the IPA study, and the IPA study have basically 3 critical perspectives: phenomenological, which looks at the experiences, and this is what I basically did. I would have looked at the experiences of young persons who would have accessed mental health services. So the phenomenological perspective, it generates rich and detailed data because you're literally having a conversation with the persons to study their experiences. It's not like a quantitative research that generates numbers, it generates data. And this approach examines meaningful experiences of the individual that look at a particular phenomenon. In this case, was their experiences of accessing the services and facilities mentioned earlier. And it also helped us to understand how young people make sense of their experience in question. The data collection methods that I would have used were interviews, and I used primarily a questionnaire and a semi-structured questionnaire with prompt question. The sample, we would have recruited a total of 6 adolescent participants. Now, we would have liked to have a larger sample size, but because of the stigma not everything associated with accessing mental services, you won't find that the adolescents who want to come forward to participate in a study like this. We did receive permission from the Arab Board of Guyana that is monitored by the Ministry of Health. So we did take into consideration the ethical consideration in terms of doing the research. And the reason why it was done with participants 16 to 19 is because we really wanted to take out the factor or the challenge of getting parental consent. So that's why we would have used the older adolescents as compared to adolescents ages 10 to 19. We would have looked at persons or adolescents that are diagnosed with a mental issue. So it could have been anxiety, depression, post-traumatic stress, and the person has to be accessing mental services in Region 4. Which is mental health unit or the Georgia Public Hospital. So out of the 6 persons that were recruited, we only end up recruiting 4 persons in the study, right? And that's why I would have mentioned earlier that it cannot be generalized because we had 4 participants that actually participated. For the study, we had a primary research question, and I'm saying we because I had a supervisor that is part of your university. So that's why I'm saying we instead of I, right? So sorry for that. Participants experiencing, the primary questions were what are participants' experiences of accessing mental services? What difficulties and challenges participants will experience in accessing the services, and how have these difficulties or challenges impact their experience or views of mental services at institutions? The secondary questions were what support have participants found to be helpful, and what can be done to improve mental health service delivery to the adolescent population. And I think the slide is too small, but the findings generated 4 main themes. Participants would have indicated that they felt supported, that the timing of mental health services, experiences of counselors, lack of mental providers, choice for adolescents, and for the support. Now, in terms of feeling supported, they would have said that when they would have gone to the institution, persons, they were warm and welcoming and adolescent friendly, and they had that support generally within that institution as compared to outside of the institution. The timing of the mental services, this was both, in some cases, based on the participants' positive and negative. What some would have identified is that the timings were not adolescent friendly, because if I'm going to go to a therapeutic session, it cannot be from 8 to 4:30. That is that I'm in school or I'm participating in lessons. It needed to be more after the school period or after period where I'm not at work, right? Two of the participants would have said that, oh, the time was okay because they felt that they could have left school and just go to session or person actually knowing where they're going during that time period. The experience of counselors, it was found that the counselors were, in terms of their academic experiences and in whether they would have dealt with clients, that it was good, but they were also saying that we need a wide range of mental specialists in Ghana, because as we know, there's only social workers or psychiatrists, and primarily at the Georgia Public Hospital, there are more psychiatrists than mental specialists or social workers. That also came into play with lack of mental provider choices. They felt that they did not have a choice to choose between a psychologist or a social worker. It was highlighted that at the mental health unit, at the time of the research, they only had 2 psychologists And yes, they had other social workers, but they didn't have the ability to choose between a specialist like a therapist or a therapist or somebody within a specialized area. When it came to Georgetown Public Hospital, that was also identified that the persons that they spoke with were more from a medical background as compared to a therapeutic background. Right? For the support, it was highlighted that as much as we have the GPHC and we have the mental health unit, they need to be all the areas where persons can be supported from their community. Because every time an adolescent needed counseling, we had to travel to Georgetown, to the mental health unit, or to the Georgetown Public Hospital to get that support. The research that they provided a positive view of adolescent experience with mental health services. At the two selected facilities, they would have said that they felt satisfied with the mental health services. The healthcare workers had positive attitudes, and they were non-judgmental and open attitudes, and they had the ability to listen. But again, as I said, this can be generalized to the entire adolescent population, because some persons might have more negative views when it comes to healthcare workers based on the facility that they're visiting. Participants found that the mental health services at both of the facilities were helpful and life-changing. However, there are improvements that needed to be in place to ensure that adults have that well-rounded experience when it comes to their accessing mental services. The research found that while the experiences were positive at the facility, our adolescents believe that they need to have more creative therapy. As I keep saying, that most of the time it's only a psychiatrist that you're speaking to. And the first time they will say that I have a mental issue, you diagnosed, the first thing they will seek to do is put you any medication rather than taking you through a talk therapy or another creative therapy, such as art therapy or mindfulness or one of the other things. And I did remember one participant saying that I literally feel like a zombie. Yes, I have anxiety, but when I go to GPHC, the first thing I'm placed on is a medication, and I'm not necessarily being helped with that medication, right? The findings also provided insight into some challenges experienced by adolescents. They, as I mentioned earlier, limited access to mental service providers. We don't want our adolescents only speaking to psychiatrists. We want our adolescents speaking to social workers and other therapists to get the help that they need. More social workers and mental health social workers and psychologists need to be at the facility as compared to psychiatrists. The stigma surrounding mental issues are still in a major factor that's affecting our young people from actually accessing services, and the logistical or environmental factors. Mental health services, again, we are trying to decentralize, yes, but we need to do more work in that area. We need to have more clinics set up in the different regions and not only having our young people traveling from Burmese to GPHC or to the mental health. We literally need to have more counseling spaces in the different regions. Some of the barriers that they would have expressed was that, as I mentioned, timing of the services or therapeutic session. You can't only have it within an 8 to 4 session. We need to have more friendly hours that are adults can participate, whether it's on Saturdays, whether it's on Fridays after work, or from 4:30 to 6. There are more times that they can actually access. We need to work on, which is another barrier, the stigma attached to accessing services. Young people believe that when they go into the mental health facility, and one of the things that came out in terms of branding is that I'm going to Georgetown Public Hospital. People know or automatically will say, oh, she got a mental issue, she mad. Why is she going to GPHC? Or if I'm going to the mental health unit, they automatically know that, oh, I probably have a mental issue. So one of the things that came out is that the branding of the facility should probably change or should change in order to ensure that our young people access services. So rather than having mental health unit, psychiatric unit, we should have a more adolescent friendly name. So if I'm going to this facility as a young person, persons will not stigmatize again, because we still have that stigma when it comes to mental issue. Location of the facility, and I think I did mention that we have GPHC, we have mental unit, but we need to have more facilities within our region. So the study findings that I would have mentioned, I did not find any findings with particular together. But the study was supported or coincided with some other researches that was done, and one view that one of the challenges faced by individuals with mental issues is access to treatment, which is largely due to prejudice and behaviors. With 2002 also would have said that persons who are associated with mental issues experience two forms of stigma, personal and public, and it's the same thing for our young people. They will stigmatize against themselves personally, and they will face stigma from the general public, whether it's with their peers or even adults within the public setting. Healthcare providers who are youth-friendly understand their clients and promote healthy changes within adolescents. And this is something we really need to work on. Yes, our healthcare workers are youth-friendly, and I can attest to that with some of the areas, because one approach that we have at the adolescent department is our youth-friendly or adolescent-friendly spaces to really train workers to be adolescent-friendly. But in the area of mental health, we need to have more training for our healthcare workers. Two stuff one we follow is related to Guyana is Dr. Thomas, who's the previous mental director. At the time that this study was conducted, stated that indeed there are limited social workers and therapists and psychologists that is attached to the facilities in Guyana. And that's one of the areas that she was working on to improve, to ensure that they have more social workers and more psychologists. And I know that discussions will start to have more persons going to study psychology, whether it's at the University of Guyana or overseas, because we need more psychologists and more mental health specialists, especially when it comes to children and adolescent mental health. Also, we would have thought that accessibility to mental facilities is a major concern, and it affects adolescent access to children and mental services. So this research would have shown that what the actually said. We need more facilities, we need more space so that we can actually access the services. In conclusion, the study adds to an understanding of the experiences of adolescents in terms of accessing mental services. It highlighted perceived barriers to mental services, and the findings indicate that while mental services are not fully adolescent friendly, there's a component of adolescent friendly services that are present, like the healthcare workers were non-judgmental or the psychiatrists were non-judgmental, etc. The study also showed that participants' experience of accessing mental services in the two facilities were positive and that they were satisfied. But as much as we will see this, again, I'm saying that it cannot be generalized the entire adolescent population across Guyana, because only would utilize for participants. In the study revealed that addressing the perceived barriers to accessing services by adolescents would enhance service delivery and increase access to services by adolescents. Now, we did not actually check to see the percentage of adolescents accessing services, but we do know that once these barriers are addressed, we'll see more young persons coming forward to accessing mental services, more particularly having a safe space and working on removing the stigma that's attached to mental services. Recommendations that were made is that more adolescent-friendly interventions need to be implemented, such as art therapy, etc. We need more policies and strategies to address children and adolescent mental services, and considering the limited research that was done in this area, we can actually do more research to find out more about the experiences of our children and adolescents when it comes to accessing services. So if you would like to find out more about the research, and I'm trying to manage my e-contact. So I have the contact, not my personal contact, but the contacts for the organization. And that's where I'm working on managing the amount of emails that is coming to my personal page. So thank you very much for listening. I'm willing to answer any questions when the question and answer. Thank you.
Okay, thank you very much. I think you brought up some very important points, and we really need more people in the field. And one thing that we thought about is step field, using low-level professionals to start therapeutic development, stepping up. So, but now we have questions from the audience. So, you can just address your questions to anyone.
I would just like to make a suggestion of your question with one of our recommendations, Ms. Glenn would have mentioned, I see that she said you need more policies, but what about if you have policies there that need to be revised? I mean, you can look into that as well, because some policies are being so old, they need updating and all of that. So I guess in that area, you can also look at that.
Most definitely.
What's your question?
I noted that you said medication is what is offered first, rather than a talk-through session and so on. I'm wondering if that's because of the volume of patients that, the doctor in the session will have to look at. Do you think it's that, or do you think it's more of, the fact that they're trained in that session, they're more clinicians, rather than therapists than them? What do you think is more responsible for them, providing medications first?
As you would have mentioned, I think it's because they're more clinically trained as compared to therapists. And then because when we started looking at mental health, it was seen more as, I don't want to use the word math problem, but that's how it was seen. And was only seen that, okay, it should be treated with a medication. But now because mental health is something that is widely looked at across the world, and we're actually seeing that not only medication can treat, but they have other therapeutic measures that is now actually coming together more and more, right? So coming out of the university, and you have to now have a psychology program, you have the social workers. So now these other professionals are being utilized more as compared to only the medical practitioners and our doctors.
My name is Sam. I've been diagnosed with bipolar 1 for 20 years. When you go to see a doctor, they will see certain symptoms. And from the symptoms, they will make a diagnosis. And then after that, you will be treated with medication. But they won't just give you medication unless they see certain symptoms and make a diagnosis.
That's a suggestion. Because you said in the investigation, you were only able to get 4 participants. Very good study, I must commend you, but for future, if you're planning on extending it, even if you had gotten 4, like 1 from each region, it would have strengthened that data a bit more. So you can get a perspective of this is not what is just happening in region 4. You can get 1 from 6 and maybe 2 or 3. So you strengthen that data a bit more. It doesn't matter if you have 6 or 4 or 2, just spread it out a bit. So the data can look a bit stronger when you present it. Right?
Yeah, so that's the plan for the future, but because of the research, we had to use the 2 known mental health facilities, which was mental health unit and GP. But the plan was to also extend it to other region, but then we had to narrow it down only to region 4. Okay.
Am I allowed? Yes, I have a question to Ms. Altavini, because I'm not a medical health professional. If you could help me understand the difference between the psychotic-like experience and the full-blown psychosis. What's that
So, sorry, could you just repeat the last part of the question?
Sure, I just needed to understand what is meant by the term psychotic-like experiences as against psychosis.
Okay, in the study, we used the self-report questionnaire, the 4 questions that measure some psychotic symptoms. We call this psychotic-like experiences because it's not a diagnosis for psychotic disorder, nothing like that. It's just some of the students that related to have some of the 4 symptoms that are measured by the scale. That has hallucinations, visual hallucinations, hearing things, delirium, and some other symptoms, but it's not a diagnosis. So we chose to use this more general term that is psychotic-like experiences, trying to not stigmatize the students that stated to present some of those symptoms. It was clear?
Yes, it's clear, thank you.
I think that's an important question, because when you say psychotic-like experiences, that's not so good.
Okay. No,
think
I just want to know because I guess maybe it's a history before you can.
I've seen this in reports when people take these psychotic-like experiences to mean a psychiatric illness. I think that many people who've undergone trauma, such as school failure, or dropping out of school, and as you said in the talk, they sometimes have dissociated experience. That's like when I see, like we're driving and here in Georgetown, when I see the cars coming straight at me, I think there's no way to get out of it. My mind goes into a dissociated state. I'm not here. And a lot of these psychotic experiences are already dissociated. Not really. I think the word psychotic is not a good thing, but because
with the focus on mental health now in Ghana, I would suggest that the government could like get crash courses for medical professionals where they bring current treatment and diagnosis, so that doctors throughout the country can be able to treat patients with mental health, so they don't have to come to Johnson Hospital. And if the medical doctor they have problem, then there's a system where they could consult with a specialist.
So if I may add to that, we're currently doing that from the mental health perspective. Doctors are being trained in the mental diagnosis, and with that, they're able to treat persons or make a diagnosis when it comes to mental issues. So we have persons that are trained around the country in all the administrative regions, and that project is led by the mental unit and in collaboration with Power.
It's open for private doctors.
I think it would work for some private institutions. I will confirm. I will share that information.
But why I'm saying crash courses like weekends, so that the time is not known.
But that particular course is not a weekend. It's a 5-day training program that will have to attend in person, and it's a power module that you go through, and then you receive a certificate in that. But there's also the Power online learning for persons that would like to participate in. It is free. You can go to Power website, and they have different mental courses that you can take at your own pace. They have the psychological first aid and all the other mental courses here. But I will find it and I will share the information with you, or you can contact Dr. Morgan at the mental unit or Ms. Alice Solomon, if they're in charge of that.
Thank you.
I have an observation. May I? Can you hear me? Hello?
Yeah.
Yes, okay. So the last speaker made the point that at most of the treatment facilities in Guyana, there are more psychiatrists than social workers and other behavioral counselors. The tendency of psychiatrists, in my experience, is to provide medication rather than do talk therapy. And I think this is it's a very important point that she made. And I think this is one of the problems that we have in terms of less talk therapy, because we have less professionals, trained professionals who would do talk therapy, such as counselors and social workers. Just wanted to make that point.
I think that's a very important point. And as a psychiatrist myself, it's so much easier to give somebody medication than to spend time talking, especially when you have a long queue of people waiting to talk to you. And I think it's not a good strategy to have psychiatrists in the front line. Rather, as I said, the step care approach, they should wait until the talking professionals say, otherwise it's so easy just to give a medication.
But I want to ask, the industry that has several school bureaucracies, right? And it's recently started.
Because you speak up,
Sorry, the education has several school bureaucracies department, and as recently employed several members of council offices. Is there a collaboration between the Ministry of Health and the Health Department? These departments will be to that early form of support and give them So students who may need some sort of intervention.
I will have to check on the collaborations that don't work directly out of the mental health unit. So I'll have to check on that collaboration and get back to you, but that's a very good recommendation. It's something that we actually take into consideration. I know for my department, in terms of adolescent health, we do work along with the Ministry of Education, school welfare department, and all the other departments that deals with health issues for children and adults.
Because of the spectrum to get.
So it gets into, yeah.
Put a pause on Dr. Fox, whether you have, if you have a staff member who's having problems, is there someone that they can turn to? Do you have outreach programs for people going on?
Okay, so we have counseling section in the university again. And their services are available for students and for. I think so we're very fortunate to have that. It's recent that we have a number of staff. There was a time when it was just one person and that person was overwhelmed. So that's really, really one of the things though is there's still it's still difficult to get people to ask for the help that they need, to acknowledge that they need help, and to ask for the help that they need. I think more conversations like these that make it mainstream, you're going to see more people actually seeking help.
If I can just add, one of the things that I was just there in Guyana, I'm in Canada, I'm Guyanese, I'm a therapist, licensed clinical supervisor, but I'm specialized in addiction. However, I do have cases where I have to be doing diagnosing work or intervention. What is it that needs to happen? And by the way, all three do amazing presentations. One of the things that needs to happen, we need to collaborate and interact and engage with the community to understand what are the languages they're using to describe things about mental illness, mental health, because they're using different languages. And like Brazil, Uganda, and several places of that, they use lay counseling. It doesn't always have to be clinical professionals who do interventions, or as someone that's worked as a trainer for Safe Talk in Canada. I work with ordinary people for them to be able to see the signs and signals of invite when people are having suicidal ideas. So for example, your presentation, amazing about college students experience, you need to consider engaging the local community. In Africa, we have grandmothers who sit under a tree and can engage with someone who's having distresses, anxieties, and then they can make referral to the limited resources we have in the professional institutions.
I'm not sure, but I couldn't understand the question.
The question, I think, is making a comment to say that don't necessarily have to use only the mental health specialists or the clinicians to do the interventions, but you can literally use persons from within the communities, and that's good. And you made reference to a project in Africa where they use the grandmothers. Yeah, and that is something that we could also incorporate here again in terms of using, because we have pre-educators at the Ministry of Health, so that we train pre-educators to work in schools with the welfare department, etc. And that is something that the mental health is also working on.
For the grandmother study, which they did in Zimbabwe,
Yeah.
it would probably, just guessing, would be very suitable for work in the interior region.
Correct. Yeah.
One other question, is there any support system with parents with patient with mental health issues?
Support system in the sense of how persons, parents receive training.
No, support system,
Oh,
financial support, because it's like this.
No, not that I know. I know the government could
There's
start the
something.
disability. The
Yes,
disability,
okay. This public assistance, if you have worked and contributed to NIS, you can get something called invalidity. Invalidity benefit.
Okay, there you go.
I would like to ask Dr. Prof and so Whitney, really interested in suicide in students. a university who drop out and fail. It seems to be, it's at least at some high pressure universities or high stress. Do you have any policies for helping students who drop out, who fail exams? Because those are highly vulnerable populations. Usually they leave the university and nobody cares about it.
Did you want to present?
Did you get a question?
Yeah, let me see if I get it. It's a little bit noisy, but I think I got it. Did you ask about if there is any policies for the students dropout and attrition rates in Brazil? Is that?
Right, if somebody fails their final exam, do you do anything about it or just say goodbye?
So in Brazil, we have different policies across the universities. Some of them have some policies to keep the students going on with the studies, to maybe try to talk to them to take a leave of absence and not to drop out the school. So trying to figure out what is happening with the students. That is, if the students reached out for somebody in the university, if he could access the services within the university to try to talk about their difficulties. But it is very different across the states and the universities. It's hard to say if there is some national policy or something that is the common ground for all the universities. Did I respond to your question?
Yes, I think so. Well, thank you for a very interesting session. I'm afraid I've been reprimanded by the authorities that we have lunches already. So really want to thank you very much for